for those who are not present for when I initially presented this about almost a year ago, this is a project I've been working on for a while with the House Staff Committee, really a multidisciplinary project, sort of piggybacking on some previous work that have been done in the NICU. But it's focusing on a standardized postoperative handoff process for the neurointensive care unit. So I want to start with a little background. It's just some background on communication in general. Lack of communication is a contributing factor, 30% of lawsuits and 37% of all high injury cases. This is a study out of the Harvard Business School. And as you know, the Joint Commission is very much on top of this. And in 2010, they required that handoffs be addressed as a patient safety parameter for hospitals. There's been a lot of literature out there. There's an excellent meta-analysis done looking at the effect of standardized handoff protocols. And they looked at it across the board and showed multiple improvements in you have handoff information in terms of the objective information being relayed, patient outcomes in terms of outcome metrics for patients, provider outcomes in terms of provider workflow, how people's day-to-day works, and organizational outcomes in terms of things such as culture changes at institutions and overall improvements in efficiency around an institution. So the specific framework that we've sort of adopted at Jefferson across multiple units is this IPASS framework. This is evidence-based. There's a randomized controlled trial and then a number of follow-up studies looking at this, comparing the use of this for handoffs to not having this used in handoffs. And they found a significant decrease in medical errors and importantly in preventable adverse events. And so this is one of these situations where you have a great evidence base for this and you can translate that into other clinical settings. And importantly in this, there was in terms of effects on workflow, there was no real change in the handoff duration workflow or contact time with patients or families. So this is sort of a landmark study in looking at quality improvement initiatives for patient care communication. So just a little background of applying this into the neurointensive care unit, specifically for postoperative patients. So, they're highly complex. Most of them are typically managed in the neuro ICU. The handoffs typically occur with a large multidisciplinary team. You have nurses, intensivists, respiratory therapists, anesthesia, and neurosurgery. However, prior to this project, the quality of the information that was being handed off was really unknown. And importantly is that a lot of our patients, especially in the perioperative period, are neurologically disabled, which makes them especially vulnerable to errors in communication, where they cannot be their own advocate. So how we adopted this in terms of quality improvement, this is, again, I do in the future want to work with you guys some more in terms of developing a language for quality improvement. What are the tools out there? This is a very common tool known as a PDSA cycle, which essentially is the part of the model for improvement developed by the Institute for Healthcare Improvement. And it's essentially a standardized framework for how to approach a problem like this in terms of developing improvement. And so you essentially have very clearly defined goals, and then you enter a cycle, a PDSA cycle, which stands for Plan, Do, Study, Act. So you plan what your intervention is going to be, you initiate your intervention, you study the results, and then you act. You either make changes, you drop it if it's not working at all, you essentially develop an iterative process, and then you re-enter the cycle with your new plan, you initiate it, you study the results, and then you make changes. So it enables you to have long-term effective change through multiple iterative processes and gain valuable feedback along each cycle. So sort of starting from the top with this, a clear point was to develop our clear goals. So one is to have direct communication of airway and hemodynamic concerns, direct communication of operative events, complications, and management goals, attendance at handoffs, confirmation of information by receiving teams, and also to have improvements in staff perceptions of handoffs as well, in terms of the what we call the culture of patient safety. So this was sort of what I had previously presented. Our initial phase was the pre-intervention phase. We did essentially a survey And you can tell briefly by the results here that in general, people did not feel that handoffs were great. The colored graphs on the bottom indicate what we call high-risk behaviors by both sending and receiving teams, in terms of senders asking for questions, for getting information, and whether or not they were happy with handoffs. And from the receiving side of things, high-risk behaviors being, not having enough information, so they have to access EMR to get additional information or find clinicians for additional information. And again, also, whether or not they're happy with handoffs. And then also there is an open text portion for suggested improvements. And you can see that there is a high favor to have some sort of standardized checklist. So this led to the creation of the IPASS framework for the neurointensive care unit. And this is IPASS is just a general paradigm that you can use and sort of plug and play whatever unit or situation or specific handoff you're addressing. So we essentially took this framework and plugged in, well, what are the pertinent pieces of information for this handoff? And it standardizes what gets communicated as opposed to individuals thinking at the time what's important. It's a standard agreed upon pieces of information. So we implemented that. We allowed 4 months. We had serial observations of handoffs, and then we did a repeat staff survey. And this was our phase 2. This is the study part of our second PDSA cycle. And we looked at the responses to the survey, as well as the initial observations. And I'll come back to the slide in a second, but these are the results of the survey. So you can see already that there was a pretty marked improvement in staff perceptions of handoffs in terms of their organization, their efficiency, comprehensiveness, and then again, looking at metrics of communication as well between teams. We did also, and then this is also a follow-up from here, is people's generally had a good perception of the IPASS format and wanted to continue it. But going back, like I said, this is an iterative process. We also found that there were significant concerns. One is that people felt they were waiting for the intensive care unit team or for the receiving team, and this was causing significant workflow delays. People were reporting that these handoffs were taking too long, too much time out of their day. The streamlining of getting patients to the room and having the right people there was just really not in place. So as part of our second phase, we actually redesigned on the right side, the actual protocol for who calls who at what time frame. So there's a very clear delineation of responsibilities. And what this resulted in is essentially the patient coming to the bed in the intensive care unit, and everyone is there at the right time point and can proceed with the handoff in an efficient manner. We also adjusted, we went into the third phase, which is our long-term follow-up. And for this, we actually adjusted our observation checklist to look for what are called balancing metrics, which are essentially the negative consequences of an intervention. And timing had been a major highlight in this. So we decided, okay, let's see if we can take a look at the timing of this and make sure that even with our new operation in place, if this is still efficient. And then we also had a case-by-case review of processes and feedback. So this is the ultimate results of our observations. Blue on the left is our pre-intervention phase, the initial observation phase. Red is our post-intervention, that 4-month phase. And then orange is the long-term follow-up. And you can see that essentially every metric we were looking at had significant improvement towards the end. And I have to say, if you look at the neurosurgical communication, pretty much every metric was 100% during the handoff by the end of this. And same thing when we look at team member attendance, and then improved synthesis by the receiving teams in terms of summarization and nursing asking questions. So I think this highlights a couple of things. One is it does demonstrate long-term sustainability of this. It also demonstrates the importance of this iterative process, which is you have that middle analysis when you can assess what's going well and what is not going well and adjust it accordingly to try and continue to improve your outcomes. And then you reassess again to see if you met your goals. And then sort of going on that, when we looked at the balancing metric, I think this is probably the most important thing for the neurosurgical residents is the mean handoff time was 4.5 minutes. And I think that when people wonder that this is too much of a time constraint, when you think of the importance that this adds to communication and making sure that everyone is on the same page, from the NICU team, the nurses, the anesthesiologists, and the neurosurgery team, and taking care of your patient you just operated on, that patient deserves 4.5 minutes of your day, in my opinion. And I think that this is a good credence to, that this has become, I think, an efficient way to spend, to have this handoff conducted. So ultimately, lessons learned from this, changes in communication require a multidisciplinary approach. Multiple teams were involved in this, and you can see from my title page how many different practitioners were involved from different teams. The iterative process adjustments, like I mentioned in the initial interim analysis, there were low rates of NICU attendance, people waiting around, and this was adjusted with the 5-minute heads-up call coming from the intensive care, or coming from the operating room before going up to the ICU. And then also including the balancing metric of time to see if there was an improvement. And also that these communication practices reciprocally influence the overall culture of safety. And anecdotally, this wasn't something we could really capture in the data, but now this has become sort of the normal parlance in the NICU. You finish a patient in the OR and they say, hey, are you coming up for IPASS? That it's sort of in the lexicon used in the NICU, and essentially is the new norm as opposed to an exception to the rule. So I think, I'm very happy with sort of where this went. I think it's sort of become ingrained in the culture, as I mentioned, and areas for improvement now, I think, is largely case-by-case basis, finding, there are situations when we can't do an IPASS, and what are the ways to get around that? One being, late at night, something like that. There's multiple emergencies going on. There's not enough people able to have those communications in a timely manner. And so how do we get around that? And that's largely being addressed on a case-by-case basis, as we are still looking at this and having open lines of communication.